So today we're going to be talking about hereditary breast cancer. We're going to talk about some things in terms of hereditary cancer testing. So the thing that I'm not going to talk about today, although I can wing it and do a chalk talk if you want to, is somatic cancer testing, right? So we're really talking about germline or hereditary cancer testing. And I'm going to try and give you a perspective, at least from my perspective, of what we've done over the last 15 or so years and how that's been changing. This is actually one of the biggest influences in terms of what's happened to us in terms of hereditary cancer testing. So this is unfortunately a family that's kind of scary family to be in. This is the young lady we're going to talk about here today. Her mother died of ovarian cancer. She had another aunt who died of breast cancer. Her grandmother died of ovarian cancer. A cousin, one of her second cousins died of breast cancer. Another aunt, another grandmother. I mean, just breast and ovarian cancer sort of all over the place. And you can imagine, if you grew up in a family like this, what an impact this could have on you. And for any of you who are interested, we actually have literally a study looking at this that's looking at girls that are growing up in hereditary breast cancer families and what that does to you from both a psychosocial point of view, from a risk perception point of view, from a health behaviors point of view. So it's not insignificant in terms of the impact that it has. The important thing about that, though, is that you actually know this person. And for any of you that saw the flyer that went around, what you'll realize is this is Angelina Jolie's family history. And Angelina Jolie is, in fact, this woman down here. She's actually a little older than 39 now. But you could imagine that had this been your family history, she was motivated to try and figure out what was going on with her. And she went through, as many of you know, and actually went through hereditary breast cancer testing with BRCA 1 and 2, was found to carry a mutation, and as many of you know, because she was very brave, I think, in terms of being able to talk about this, eventually, although it took a while to get to this point, eventually underwent prophylactic bilateral mastectomies and then prophylactic oophorectomies. And so she, being in this, sitting in this family, knowing that she was going to be at high risk, and we'll talk about how high that risk is, wanted to take pretty aggressive measures in terms of risk reduction. This is now sort of, for those of you who are interested in the societal impact, I'll tell you that one of the things I find interesting is Christina Applegate. I didn't actually put her family history up here. It's not quite as severe as Angelina's is, but Christina Applegate had not a dissimilar family history, also carried a mutation, also eventually went through prophylactic bilateral mastectomies. But she didn't actually have the public impact that Angelina did. And we can talk amongst ourselves in terms of why that is. And maybe it was sort of an additive effect. You know, Christina had to come out first, and then Angelina had a greater impact. But it is interesting that if you look at the volume of what happens with hereditary testing, Angelina's effect, I would say, was twofold. One was her actual impact in terms of impact on society, on women, acceptability of being able to pursue testing, as well as still look gorgeous and beautiful afterwards after having surgery. And I'll also argue that it had also to do with access to testing. That is, when Christina came out with her story, there was still limitations in terms of being able to access the type of testing, as opposed to, if you look at in time when Angelina came out with her statement, this was much more accessible in terms of being able to actually get hereditary testing. So I'm going to say some provocative things as we go along. They're intentionally meant to be provocative because I want to get your feedback and input on this. This is very much an evolving field. I would say one of the most rapidly evolving fields in terms of gene screening, sort of health screening in a genetic point of view, and ways of thinking about this. So I'm going to talk mostly today about hereditary breast and ovarian cancer, although I don't mean to sort of give short shrift to either those of you who come from families or know of families with Lynch syndrome or von Hippel-Lindau families or anything like that. I just simply can't cover too much territory and still keep everyone with me as I go along, so I'm going to hopefully make it accessible. But when you think about this, I spend a lot of time seeing families who have breast cancer, or individuals who have breast cancer, those who have family histories of breast cancer. I also don't want to oversell this, though. Right, so 70% of the patients who are diagnosed with breast cancer every day, in fact, have no family history of breast cancer. So for all of you who don't have a family history of breast cancer, this doesn't mean you don't need your mammograms, although some people will argue from a public health point of view how effective mammograms are. I still believe in them. But when you think about those people who do have a family history, and we do a lot of modeling to understand this risk, it's really still a modest percentage of those that we will actually find a genetic contribution. Not that there isn't a genetic contribution, but in terms of what we can find these days, it's still relatively modest. We'll be talking about this slice of the pie mostly today. This is the 5 to 10% in which we can find a single gene that's either what I would say causative, meaning probably more than 80% of the risk for that person, or increasingly we'll find genetic contributions which I'll call contributory, but not that they are the one and only factor that's determining risk in those individuals. There's clearly a lot still to go, and as many of you know, you can actually see a very recent paper in Nature Genetics looking at GWAS studies, genome-wide association studies for breast cancer. There are now over 75 different single nucleotide polymorphisms or other traits that increase the risk of breast cancer. So this spectrum of risk really is exactly that, from what I would argue are very highly penetrant single genes, all the way to things that modify the risk by relative risk of 1.2, and we have everything in between. For this slice of the pie, this 5 to 10%, it's very interesting because when Mary Claire King first did the linkage studies, then when investigators in Utah actually identified BRCA 1 and 2, it really had a profound impact on the field, mainly because, number one, I would argue there were common mutations, and we'll get into that in a second, but this was something you actually ended up finding quite a bit about. In other words, the clinical yield was reasonable. And number two, they ended up having pretty clear impact in terms of recommendations. So the risk was high enough, and that there were things that one could do that were actually medically actionable, that it actually, I would argue, had a very, very profound effect in terms of how we think about cancer genetics and in general how we think about the medical impact of genetics in general. The two genes that are most commonly thought about are BRCA 1 and 2. Number one gene accounting for about 50% of this 5 to 10%, so about 5% of all breast cancers, and BRCA 2 as well. And increasingly, this slice of the pie, this 16%, with these other single gene factors increasing over time, but much more modestly, I think, than any of us predicted. So just so that we're all talking about the same language, and I apologize for those of you who know these statistics already, but BRCA 1 and 2 are absolutely high-risk genes in the sense that some of the things you'll see Angelina actually quoted when she gave her New York Times op-ed on this. She said, "I was told there's an 85% chance that I'll develop breast cancer." The good and the bad about what Angelina said was that in some studies, that risk is as high as 85%. When you actually do the meta-analyses, looking at all the aggregate data together, the risk is really only about 50% lifetime risk of breast cancer. So, number one, the risk at least was initially thought to be extremely high. Once you start digging in deeper to those other families, those lower risk families, those population-based families, not quite as high. But this is a risk that increases clearly over one's lifetime. But the thing that's obviously very impactful is it starts quite early. So many of us have seen women as young as 25, 26 years old with hereditary breast cancer. The risks are not high in terms of the percentage risk in the decade of the 30s, but it does start that early. And so when we think about screening recommendations, not just our guidelines, but NCCN guidelines, we would start screening for breast cancer at the age of 25. Importantly, that age is not 15, right? So it's not 5, it's not 15. Women, the good news from our point of view as we conceptualize this is they're adult women, so they have ability to think about this, to make decisions for themselves, independent decisions for themselves. But on the other hand, they are sometimes young women. So women, for instance, if you think about life course and where you are in life, I can tell you I've had more than one medical student that's come to me that we've put through testing when they were first, second year medical students, and they're in their early 20s, 25, thinking about this. They haven't figured out their life in terms of who they're going to marry, whether they're going to have kids, what their specialty is going to be. They're sort of all still figuring this out. And that's for many women in this decade of life where they are in life. And so one of the things that I always urge women to do is you decide where you're going to go on your life course, and then you ask us to help you adjust to that in the sense of what screening you need to do, what interventions you need to make. But don't decide to have all your kids by the time you're 30, just so that we can take care of these medical issues. And I have rarely, but I have seen women that do it that in reverse. That is that they let this drive their decisions. And I've almost always seen that ends up being not a great decision in terms of broken marriages or women that have regret after they have some of their surgeries. So I think it is an important message to give them. The other part of this risk, so this is the cumulative risk of breast cancer for BRCA1, BRCA2. We generally counsel women that they're more alike than they are different in the sense that they still are relatively highly penetrant, but in general, BRCA2 has lower risks associated with it than BRCA1. And so those risks in BRCA2, again, the highest risk I would argue is probably something like 60%, but the absolute risk across the meta-analyses is probably more like about 40%. The other part of this is the ovarian cancer risk. And the breast cancer risk, I think many people, many patients, many of us feel more comfortable with in the sense that we have screening. So we have things like mammograms, we have breast MRI. Obviously, there are things that we can do in terms of risk reduction. Kathy Crew here is one of the people who's great at thinking about what we can do from a medical point of view in terms of risk reduction. And then in terms of surgical risk reduction, obviously there's prophylactic mastectomy. The difficult portion of this equation is really, in my opinion, the ovarian cancer risk part of this, because although the risks are lower, about 40% lifetime risk for BRCA1, about 15% for BRCA2, we really, much to my chagrin, still have no good screening test for ovarian cancer, right? So many of you know we tried and still try using something like a CA125, but it has false negatives, it has false positives, and unfortunately it's very likely to be a lethal condition if we leave it to screening alone. And so our recommendation still is to do prophylactic oophorectomies and salpingectomies. For those of you that are interested in the biology, it's most likely that those tumors actually start in the fallopian tubes and spread in terms of it looks like ovarian cancer, but it probably started out as fallopian tube cancer. So the reason this becomes an issue is that you can see if you look at these risk curves, this risk of ovarian cancer starts in the 40s, a little bit later for BRCA2, but importantly, when these women, when they're premenopausal, and those cancer risks can start as high or even as early as the late 30s. And so there's, especially I have to say in New York City, what I call this clashing of the universes. That is, you have women who in sort of 20 years ago or even a generation ago might not still have been of reproductive age when they were in their late 30s or early 40s. But I can tell you based on my own life experience, you can still be of reproductive age at that period of time in your life. And you may not be ready to give up your ovaries if you're not ready to give up the idea of having children. In addition to the fact that it obviously can put you through menopause, and many women don't want to go through menopause when they're 40 years old. And so it's an interesting sort of tension that women have in terms of thinking about knowing that they probably need to at some point do the surgery and have prophylactic oophorectomies, but on the other hand playing this waiting game in terms of when you can do it and still maximize the quality of life that goes with that. So again, I think Angelina's had a big impact both in terms of being brave enough to do both surgeries as well as talk about it and share that publicly. The other recommendation or the other issue is not just in thinking about preventing cancer in the first place, but for women who've actually had cancer, being able to make sure they don't get a second cancer. So we're not talking about a recurrence of the cancer, but we're really talking about minimizing the risk of a second primary. And so one of the things, and I know Kathy would probably agree with me, really now for all of the women with breast cancer who are coming through our cancer center, they are at least offered the option of being able to have genetic testing for BRCA1 and 2, specifically because of this risk of a second cancer. So even within the first 5 years, there is an increased risk of up to 15% of having a second breast cancer. If you take that lifetime risk, it goes up to 35, even some estimates up to 50%, as well as another risk of ovarian cancer of about 10 to 15%. And this part of it, I would say, is especially tragic, and I've even seen doctors sued over this, which is that if you had a hereditary breast cancer, if you had an obvious family history and you didn't offer genetic testing to the woman when she could have done something like risk-reducing oophorectomies and then ultimately dies of ovarian cancer. So that's one of those great tragedies that we try and prevent by allowing those women to make those decisions. So let me also say that one of the things that's been interesting that for us to see, or I've been very pleased for us to see the change over time, is that in the old days, and by the old days I mean 15 years ago, 10 years ago when we were doing this, it would often take us several weeks to be able to do this type of testing and get these types of results. And I think all of us pushed very hard from the patient-centered point of view that in specific circumstances we needed to have those results stat, if you will. We need to have that information in real time to be able to guide patient management. And that was especially important after a new diagnosis. That is, a woman gets a biopsy, she gets an initial diagnosis, she's trying to make a decision at that point, she gets a cancer diagnosis based on her core biopsy, and she's trying to make a decision, does she do lumpectomy, unilateral mastectomy, bilateral mastectomy, from a cosmetic point of view, from a sexuality point of view, very important decisions for her to make, but oftentimes driven by this exact question: am I likely to have another cancer down the road? And so with this, I think that we really push very hard on the diagnostic labs to be able to turn that turnaround time from something like 6 weeks down to 4 weeks, and now even to 2 weeks or 10 days, and 7 days in some cases when we need to, at least for these two genes, to be able to get that information in real time to drive patient support. The interesting thing that as we've done that, I would say it's been a bit of a sort of from a societal point of view, interesting to watch. And that's what I would say is at the very beginning, in the early days, and sometimes I even watch these old television shows where this will come up. So Grey's Anatomy, for instance, when they deal with this, right, when you watch the old shows. So when you look at this, in the old days, it was like, OMG, it's like earth-shattering that you're going to be thinking about dealing with this or thinking about bilateral mastectomy. And it's just sort of the conversation has come around enough that people have thought about it. They've even thought to themselves, well, what if I were in that situation? What would I do about this? So in the early days, we almost never had women with new diagnoses getting testing. I mean, Kathy can probably remember this when we were fellows and, started doing this. You would do this sort of after you were done, right? So it would be like after you had your surgery, after you had your chemo, after you had your radiation, once you could get back down to, settling down, then you would think about the genetic testing and deal with this. As opposed to now, it's just front and center, right at the beginning of things. And it a little bit, for some women, rocks their world in the sense that they're doing this, you can watch their head spin. They're trying to make all of these decisions simultaneously with, as much information as they can, but they're trying to do it in a period of about 7 to 10 days. And it's just like fast forward for them. So I'm not saying that's good for all women, but there are some women who it is good for, because ultimately they don't have to go through multiple surgeries. They can just be done with it if they can get their arms around it. So what I find personally is that for those women who come from a family history of breast cancer, they've been thinking about this before, right? I mean, they've had those scenarios. They've thought through this. They were watching the Grey's Anatomy and say, well, what if that were me? What would I do? And so they've thought through those scenarios, and I find that now, in today's society, as they've thought about that, they've actually arrived at their own decisions when that day finally came. I think it's harder for women who don't have that family history. They haven't been running through those scenarios for the last 10 years. They haven't sort of put themselves in those places. But at least today, I would say there are many more women who have sort of come to that, and they're okay with it. I don't say they like being in the situation, but they're okay with it. And some of you may have seen especially some of the students may have seen some of my patients talk about this. I think they actually feel better in a bizarre way by having closure about knowing what caused it and knowing that I can define it. I know exactly what I'm up against. I know how to deal with it. I'm empowered, and I'm going to go forward and be aggressive. So it's been interesting to watch. And one other sociological thing I'll say about this, and I apologize, I don't have my slide in the deck about this, but one of the biggest things that changed, at least my practice within this, was when the founder mutations for these two genes were identified, the Ashkenazi Jewish specific founder mutations in 2 in BRCA1 and 1 in BRCA2. And that really, for those of you who don't know, 1 in 40 individuals of Ashkenazi Jewish descent who are walking the streets of New York, regardless of your family history, will have one of these 3 mutations in one of these 2 genes. And so, number 1, it became very cost-effective to screen individuals of that ancestry. Number 2, it raised awareness within that community, and so people were talking about it, thinking about it. And number 3, you ended up in positive circumstances, not infrequently. So that is, in other words, it wasn't like 1 in 1,000 women with breast cancer that would end up having this. Specifically within that community, actually very, very common, especially with ovarian cancer, but also with breast cancer as well. So it was a conversation that many people had had. Many people knew someone. They knew someone in their synagogue, they knew someone in their community in this situation. I won't have time to talk about this specifically, but those of you who are interested, again, I'll point to Kathy and Paul, have thought a lot about this, specifically Kathy, actually. Within, when I say Ashkenazi Jewish community, it is really not a single community in terms of from a cultural point of view, how individuals deal with this. And thinking about that, there have been different portions of the community who one could understand would have different reactions to this information. Individuals, for instance, who many of you know our patient population population here in New York, some of the more conservative or orthodox, the Hasidim, for instance, that's not necessarily something you even talk about, that you've had breast cancer, much less talking about there's a gene in your family or what to do about this. And so the idea of family communication or sharing this information within the family, especially when it comes to matchmaking and how that's done in the community, very, very different from a cultural point of view. So interestingly enough, and for those of you who want to in the Q&A, you can ask Kathy, because I think in a good way, again, they're starting the conversation. What I'm waiting for, and I don't know that it will ever happen, but who will be the Angelina in that community? So if there is someone in that community who's brave enough to come forward and actually tell their story, not just actually act upon this information, but tell their story, is the greatest effect that I've seen in communities with this. So in general, when we see this, the red flags, just in case any of you are scrolling through your own head in terms of your family history, young breast cancer, bilateral breast cancer, men with breast cancer, ovarian cancer. Those are the things that are just big red flags for us. On the other hand, BRCA2 is not exclusively associated with breast and ovarian cancer. We also see pancreatic cancer in a series that we've done here at Columbia. We see it with fair frequency, especially within our Jewish population, being associated with pancreatic cancer, melanoma, and prostate cancer also in men. So red flags that we look for as we're doing this. The good thing, as I said, is that there's news. This is news you can use. You can act upon this information. There are actually NCCN guidelines that help in terms of coming to standardization about what you do about this in terms of screening. As I said, breast and ovarian cancer screening, breast better than ovarian cancer for screening. Also knowing that we have risk-reducing strategies, even including something as simple as birth control pills to decrease the risk of ovarian cancer by as much as 50%. So again, news you can use, and some of it quite acceptable, at least for some periods of time. Just to give you some examples, again, this is the risk of ovarian cancer being reduced by as much as 50%. Medications like tamoxifen, again, reducing that risk by as much as 50%. Interestingly enough, most women, I would say, probably 50 to 1 would choose oral contraceptives over tamoxifen in terms of risk-reducing strategies. Still, I think, concerns about any medication that might have any sort of side effects whatsoever. And then from a surgical point of view, obviously extremely effective, but not 100%. So even though we try and remove every single cell that might have the malignant potential, we can't get all of them, and so those are greatly risk-reducing, but you'll always hear us use that terminology of risk-reducing, not completely preventative as we do that. This is not as important for BRCA1 and 2, but it becomes incredibly important when I'm going to tell you about what happens beyond BRCA1 and 2. So the results are relatively simple in the sense that you would think, well, they're positive or they're negative, right? That life should be so easy. Unfortunately, they're not, and that has to do with just normal human variation and the fact that we have not cataloged all the wonderful normal human variation there is here. And so there are cases in which it's very, very clearly pathogenic. Very clear cases in which it's completely benign, but over time we see that there are a lot of variants of uncertain significance that get clarified once we get access to more and more data, but this is a dynamic process. The less data you have, the more uncertain you are, and that makes a lot of sense. Within this, and again, I think this audience, just looking at you, this is a very basic primer in this, but we always want to test first, when we can, someone who's affected in the family to figure out what's going on in the family, identify that mutation, and then do specific family member testing with that family-specific mutation over time. So what's interesting to watch over this, and just pass down here, is that we got stuck on BRCA1 and 2 for way, way, way too long. So we were actually stuck in BRCA1 and 2 mode for about 10 years. And again, when you think about this from a societal point of view, and many of you have heard me speak about this, this really came down to gene patents, and that we were in a situation where we had patents on BRCA1 and 2, we had exclusive licenses, so we had essentially one laboratory, Myriad Genetics, very good in terms of what they did, but as many of you know, they set a price of about $3,600 for testing. They set the turnaround time, and they locked in basically the test to be a BRCA1 and 2 test. And sometimes they froze the technology. So for a long time, many of you will remember, they did sequencing, they didn't do complex rearrangements, they didn't do deletion duplication analysis, and you really couldn't go beyond that, because even though laboratories might have offered Li-Fraumeni testing for P53, the yields for just P53 was so small, so modest, that it really didn't make economic sense to be doing testing for P53 unless you had a very clear Li-Fraumeni family. family. So as a result of that, we really got stuck in this mode. And I won't go through this. Some of you have heard the story, but a few of us got a little upset by this, and ultimately we overturned this at the Supreme Court. But it was just amazing to watch that within literally a month of when gene patents were overturned, what happened in terms of the testing laboratories and their response to this in terms of offering testing. I know from the inside now, after the fact, they were watching us very closely, and they were like poised and ready to go the moment the Supreme Court decision came down, because they were convinced that it would come down. And in a good way, from any of you who watch this, what's the lowest price that I can get now for clinical genetic testing for BRCA 1 and 2? The answer is $250. Is that amazing? I mean, when you think about the markets and exactly, and now you know, those of you who are economists or business people, you can do the math, right? How long was Myriad doing this? How many tests were they doing? You can actually go back and look at their profits and everything else on this. They were raking in the bucks for a long time when the real cost of this testing was actually incredibly modest in terms of what the cost has been driven down to now. So anyway, I will put that aside. But the good thing is that, like I said, now really this becomes quite accessible. And so I won't actually ask you to raise your hands, but now if you think about this, if cost of testing could be as little as $250, this changes the equation for a lot of people in their heads, right? A lot of people at $3,600, I can tell you the calculus. Patients were coming in and they would say, question number one, does my insurance cover this, right? I mean, that was like the first thing. Now at $250, it becomes, well, you know, maybe instead of getting away for the weekend, I'll buy my genetic test and I'll make sure I don't have hereditary breast or ovarian cancer risk. But the point is that it really changes quite a bit in terms of both how our healthcare system thinks about this, how the individual patient thinks about this, and again, with the acceptability of thinking about how to do this. More importantly than that, though, to me, is that it opened up the opportunity for laboratories also to improve the quality of the testing, right? So now you suddenly have the opportunity to get a second opinion. And I have to say, just this week I had a woman come in. She came in with her BRCA 1 and 2 result from 2 different laboratories and 2 different results. And you know, the first one, if she had believed only her first one, it would have been a positive test and she would have had bilateral mastectomies. She got a second opinion from another laboratory that was a better laboratory. It was completely negative because we realized that although they saw the same sequences, the interpretation varied differently. She completely did a 180, of course, in terms of what she's deciding now to do in terms of her surgery. So this is the first time now, you know, in this era that you could get second opinions. Beyond that, they improved, and the laboratories have fought fiercely in this, and it's been good to watch, improving the technologies, going not just from sequencing to looking at complex rearrangements, MLPA, deletions, duplications, promoter variations, and importantly, going beyond BRCA 1 and 2. And that's what I'm going to spend most of the rest of the time talking about. So we realize that there are other other genes that can be involved, and I apologize because I know this is small and not projecting very well, but this is just one of my families who the proband here has breast cancer, her mother has breast cancer, but it's complicated because there are a lot of other types of cancer. We've got a prostate cancer, a renal, a pancreatic cancer, lung cancer, breast cancer, brain cancer. If you're one of my cancer genetic counselors, we sit here and we scratch our heads and we say, well, there's some breast, but there's a lot of other stuff going on. Is this just because people are old and they get cancer and you have to die of something, or is there some other complex gene syndrome or cancer syndrome that's going on here? So, you know, in the old days, we would start with BRCA 1 and 2, and if that were negative, which it was in this family, what would you do next? And so for those of you, some of you who know this, we have several options. Could this be a family that has Lynch syndrome or hereditary colon cancer syndrome? I don't know. Could be. We see some of the associated cancers. Could it be Cowden syndrome? Could it be something that's associated with breast cancer, uterine cancer? Could this be Li-Fraumeni, one of these cancers that you can have anywhere in the body, essentially? Could this be one of these moderate risk genes like PALB2 or CHEK2? You know, it's hard to tell just by looking at this particular family history. So what do? Do you start going down the list? Do you take one by one each of these different tests and start adding them on? I'm going to let you guess. So if you did these individually, one by one by one, and went down the list, what do you think your total cost of testing ends up coming to if you start going down this sequentially? Actually comes up to over $11,000, right? So if you did these individually and started adding them up, incredibly expensive to be able to do in this way. So What's the good solution to this? Well, we're in the era of next-gen sequencing, right? Like, just screw it. Just blast through it and get all the data and come up with the answer, right? So this is what we've now started thinking about, or at least started offering the possibility. I mean, many of you who know me know I'm pro-choice. I want the patient to make the choice that's the best choice for them, but let's offer them possibilities. And so the interesting thing to think about, and this is where, again, you have a vote in this, is how do we do this? So one of the tensions is the following. As we're doing this, we are learning as we go, right? We're making the plane as we're flying it. And I have to say, sometimes we crash a little bit as we go along. But as we do this, do you wait for a gene to be an incredibly well-validated gene? Do you require that it has a certain penetrance, a certain lifetime risk of cancer associated with it? Are you willing to take only highly penetrant, very impactful common genes? Are you willing to take genes that have a moderate risk, maybe a twofold increased risk of breast cancer? Are you willing to take genes that are incredibly rare, that might only be 1 in 5,000 individuals? I mean, where do you draw the line as you're doing that? Or do you just say, give me everything? Just give the patient as much information as they can want, and we'll make it up as we go along. So if you watch what's happened in the market with this, you can see the laboratories, and by the laboratories I mean everyone from, there are many companies now in this space, it's very crowded, and in a good way very competitive, everyone from Ambry to Myriad to GeneDx to Color to Personalis. I mean, you can go on and on in terms of the number of laboratories that are in this space now, but many of them offer now essentially a test menu where you can figure out what's right for you. So some laboratories have something that they'll call a high-risk panel, and for those of you who, again, are genetic counselors or geneticists, you'll recognize these types of things. They're sort of the classics of what we used to think of, classic genes for Lynch syndrome, classic genes for hereditary breast ovarian cancer. We understand them very well. They're all associated with the NCCN guidelines. We know exactly what the natural history is. There's news we can use. We feel, if you will, us as physicians, we feel very secure in that space. The thing of it is that we just didn't used to bundle those together. In those families that sort of had a little bit of everything, we never had this option. Now we have this option. These are for individuals that are a little bit more forward-thinking. So these are genes that are now a moderate risk gene. And at the national meetings, for those of you who have ever listened to us have very public debates over this, I can tell you it can get ugly because there's quite a bit of difference of opinion about whether or not we should be offering these clinically. Some of you may have seen recently that came out in the New England Journal of Medicine, essentially a very big commentary about whether or not we should be offering these types of moderate risk genes, because someone, for instance, a woman with a CHEK2 mutation, it is confusing for women to hear, I've got a breast cancer gene, because they've been conditioned to think that they're all Angelina Jolie genes. And they don't always make the distinction about, now I've got a gene with a relative risk of 2 versus I've got a gene with a relative risk of 10, and what difference that means in terms of their clinical management. So it's been understandably confusing. Our patients have sort of learned, the 101 version of genetics, but they haven't learned the advanced course of genetics yet, and that's where we need to teach them. The other part of this is that as these new genes are coming out, again, many of these are coming out, and although they are clearly, I would argue, well-validated genes, they really are just breast cancer genes, we don't clearly know enough about them to know what the natural history of those genes are. And one of the problems we have in genetics is that always the first risks that we estimate are always way higher than what they ultimately end up being. We start seeing the tip of the iceberg in terms of the families, with the worst family histories, where these genes are identified, where we see them initially characterized. And it's only over time that we really see the full spectrum of what those families look like, or even individuals who don't have a family history of those cancers. So that's what the tension has been. So this is just a slide that actually shows many different opportunities. The main point in this case being is that this particular laboratory offers over 40 options, 40 different genes that you can order. You can it's like a Chinese menu. You can take a little here, you can take a little bit there. They've made these relatively site-specific, so if you have, breast cancer in your family, take all genes with breast cancer. If you have colon cancer in your family, take all genes with colon cancer. And they will even do this, and so these are some of the different things that they offer, and they will even do this literally as an a la carte. So you can do this and you can say, I want one of these, I want one of these, or just give me everything. And for the same low price, you can have all of those different things. The thing that's been interesting to watch, for those of you that are more into the economic side of these things, is what's been interesting for me to watch is what insurance companies deal with in terms of this information. And so some families or some women have thought about this and they've said, well, you know what, I would like to have, a confined list of genes that are very well defined. I will know what information means from those. I will have clear guidelines. I will not have lots of variants of uncertain significance that will cause me angst. In other words, I will have news I can use. So they'll get that and they'll get back a negative test test results, and then they'll come back to me 6 months later and say, you know what, there's just like this, itch I can't scratch. I feel like there's still something going on. I'd now like to go on and get some additional testing, right? I don't want to stop there. It's sunk in, and I still want more information. And we'll go back to their insurance company, and their insurance company, understandably, will say, you know what, you already had your testing. You're done. We've paid for that. You don't get any more. If you want to have more testing, you go pay for it yourself. And so it's been this interesting dynamic that I have to admit I hadn't thought about at the very beginning when we started doing this beyond BRCA 1 and 2 testing. So the question now has become for many of us, and as we're thinking about this and trying to advise patients on how to do this, is do you have to go for essentially more information up front and then keep it in your back pocket, because this may be your one chance at getting the information. You may not get two chances at doing this. So do you go for a very large, expansive panel, even though you know that you might not understand what that information means, either because you get a variance of uncertain significance or because you don't know what the risks are for that gene, but at least you've got the information. And you can keep it in your back pocket, and over time, as that becomes clearer, at least you've got that information to be prepared for. And so it's been just interesting for me to watch in terms of now what's driving decision-making in terms of how much information to be able to get from this. And at some point, I think as many of us believe, at some point people will have all the information from all of their genes and we'll put this to rest, but that's not going to happen for a few years now. So as we're thinking about this, this is what the tension is. So I didn't make this explicit enough, but these variants of uncertain significance are not infrequent, right? So if you start doing now many genes, if you do up to 50 genes in your panel, and this is what I would call a comprehensive test, those rates of variants of uncertain significance can be as high as 37%. And so it is not uncommon to get one of those. And so what I always tell my patients, and they're lucky, I always say this, I think they're lucky they come to me, but I always tell them, if I tell you to worry, you should worry. Because I'm going to give you a second opinion, essentially. I'm going to do my own variant interpretation, no matter what your lab tells you. I'm going to tell you what I think about it. And if I'm worried that it's pathogenic, because it looks pretty scary by every prediction algorithm I can see, I'm going to tell you to be very worried about that. And on the other hand, sometimes we can see, because we've got our own internal databases of large numbers of normal people or other things, where we can see that this is just a common polymorphism, and I will tell patients, you know what? Don't worry about this. We'll come back and revisit it, but it will undoubtedly be reclassified. And thankfully, I've always been corrected. Whenever they've reclassified these, downgraded these, in fact, we've been right and they haven't had to worry needlessly. So my patients, I'm not worried about that. And it's good, in particular, in this neighborhood that that's the case, because with our population that's incredibly, wonderfully diverse, our rate of variance of uncertain significance is actually much higher than this. So we'll get over 50% of variance of uncertain significance in our community because we are so heterogeneous. And with a patient population that has low literacy, that actually becomes much more problematic. This idea of how do you communicate a variant of uncertain significance when you don't even know how to communicate a mutation within your family becomes quite complicated. So because of that, that's the tension. If you get more information, that's great, but it also can be potentially very anxiety-provoking, especially if you haven't had good pre-test counseling, if you don't have a lot of genetic literacy, if you don't really know or understand what all of this means. And so that's the tension that I think we're starting to see nationally, and that's why that New England Journal of Medicine paper came out, because of that concern for many of those other individuals, especially in the community, who are not necessarily at great cancer centers or seeing a lot of good geneticists and genetic counselors to know what to use with this information. So the limitation with this, again, is this tension about which one you go. Do you do more targeted? Do you do broader? I won't say that we have the information yet, but it is this tension in terms of thinking about that and thinking about what to do. So the opportunity for these gene panels is, again, potentially sometimes that you may even find something that you're not expecting, depending on, perhaps it's because the person didn't know their family history, perhaps because they were adopted, perhaps just because there wasn't something we recognized. Perhaps there was a de novo mutation and you wouldn't have the family history that went with it. But for a lot of reasons, you may actually come up with something that you didn't recognize. And I'll show you a case of that in just a second. To give you some numbers in terms of what those risks are associated with some of these genes, again, sort of for a guideline, here's BRCA 1 and 2. Some of the other genes, this is a gene that does have big implications. CDH1 is associated with lobular carcinoma in situ in the breast, and also with an extremely high risk of gastric cancer cancer. And so women that have those mutations, the recommendation is actually to have a prophylactic gastrectomy. And let me tell you, that has an impact in terms of your daily life in a big way. So that's a big impact in terms of thinking about that. P10 has big implications because although that can be associated with some benign hamartomas and breast cancers, can also be associated with having a child with autism. And so doing this starts to, you now have to think about not just your own breast cancer risk, you now oftentimes think about your reproductive risk, potentially having a child who's disabled. Other things like Peutz-Jeghers can be associated with colon cancer, in fact, very high risk of colon cancer. And again, P53 can be associated with cancer. This is Li-Fraumeni syndrome, can be associated with cancers from head to toe. And so thinking about how you screen, literally, we were just talking about one of my patients earlier, you literally screen by MRI head to toe as you're doing the screening for that condition. So the good and the bad is that you now start shotgunning it essentially. So this is what happened with one of my patients. This was a patient who had ductal carcinoma in situ at the age of 55, not terribly early, but on the youngish side. She'd also had a thyroid tumor, again on the youngish side, and had some skin cancer, squamous cell carcinoma. Like 3 strikes, so 3 different independent types of cancer, but on the other hand, none of these extremely unusual in terms of their types of cancers. And otherwise, in terms of the family history, pretty large family, really not so much in terms of what you would think about in terms of the cancer family history. So she came in not really too worried about this. You know, we did her by all these different models that we use, her Klaus model, her BRCA Pro, her Bodicea, you know, doing all these types of models. She didn't come up that high in terms of prior probability or pretest probability of having a mutation. On the other hand, we ran one of these panels, and I have to say, I was a bit surprised when she came out and had Li-Fraumeni syndrome. She had a P53 mutation, extremely well documented. This was not simply a somatic mutation we found in the blood. This was a real bona fide, honest-to-goodness germline P53 mutation. So this went from her, from thinking about, from DCIS, she was just thinking about literally having a simple lumpectomy, to now, you know, radically different change. Interestingly enough, she took it in a very, very positive way, but radical change in terms of what she was going to do for cancer screening and cancer prevention for the rest of her life, and in fact now for her 3 children, for them going forward. I will say one of the things that gets a little bit complicated with this is Li-Fraumeni can also be associated very characteristically with sarcomas, and in particular with pediatric tumors. And so we actually have not a fair number of our children with sarcomas here in the Cancer Center that have it due to this. And in this particular case, we ultimately learned that her mutation was due to a de novo mutation, which is, again, not uncommon for us to see with Li-Fraumeni syndrome. So this was the thing that changed her in terms of thinking about this. Patients with Li-Fraumeni syndrome, more likely than not, will ultimately die of cancer, but it may not be their first cancer. It may be their second, it may be their third, it may be their fourth, but oftentimes they live a life with cancer over time. On the other hand, as we're learning more about this, many of them don't necessarily have cancer early. It may start in midlife, but it may be continued in terms of that anxiety about cancer risk going into the future. And so that's the fine line that one walks in terms of potentially trying to be exhaustive, trying to learn about all this information, and importantly, trying to use it for therapy. So for instance, one of my Li-Fraumeni patients now, she happens to have invasive cancer, and we're trying to make a decision that we'll probably make over the course of the next week or so. Should we radiate her? If we know that with this particular genetic predisposition, if we radiate her within the field of radiation, we are going to increase her risk for another cancer. On the other hand, if we don't radiate her, maybe we're not going to get rid of the cancer. So how do we walk that fine line in terms of thinking about treatment now versus risk in the future? And so it gets to be complicated, but still helpful in some ways to know this now rather than later. So as we do this, and as I said, we oftentimes try to minimize radiation as well as increase our cancer surveillance, but that ends up starting quite early and quite long. The newest data actually that has come out of Sick Kids in Toronto actually demonstrates quite good the efficacy of doing this, at least in children. So I don't think we have good data, good long-term studies in terms of adults, but at least in children, the cancer screening seems to be quite effective. So this is a series that I actually have written a paper on that now looks at 10,000 patients who have been screened in this way. So it's beyond BRCA 1 and 2, now thinking about gene panels as you do this. And as you think about what the yield is for these individuals, in this dark purple here, I'll start with the number of individuals that are affected. How often do you come up with an answer? In general, the answer across the board is about 15%. So we're doing better than that 5 to 10% we were talking about originally. We're getting higher in terms of the yields for doing it, but at the same time, we're also including genes with this modest risk that goes into it. And so whether or not that modest cancerous gene is accounting for all of what we're seeing for that cancer risk is not completely clear to us at this point. But at least the yield is definitely getting better as we're doing these larger gene panels. As we're doing that, though, still in terms of breast cancer, most of the yield is coming from BRCA 1 or 2. And so if you wanted to just focus in terms of where you were going to get the most bang for your buck, it still is BRCA 1 and 2. But it's increasingly and interestingly coming from other genes I wouldn't have predicted. So within this series that we did for hereditary breast cancer, actually 6% actually came from positive, from genes that were Lynch syndrome genes or hereditary, what we used to think of as colon cancer genes. But it looks to me like there's actually at least some increased risk of breast cancer within those families as well. So increased spectrum of cancer that I think we otherwise hadn't been predicting or worrying about before, as well as some of these moderate risk genes that I was saying before. For ovarian cancer, again, most of the yield is coming from BRCA 1 and 2, but again, a fair percentage, which we would have predicted actually in this case, coming from Lynch syndrome genes, and again, other new genes, some of them coming out of Mary Claire King's laboratory, and some other ovarian cancer genes that we now know more about. And when it comes to stomach or colorectal cancer, again, most of them out of the Lynch syndrome genes in this point, but on the other hand, reciprocally, BRCA 1 and 2 appear to be associated with a slightly increased risk of colorectal cancer and stomach cancer as well. So the bottom line is these cancer spectra, although I don't think they're highly penetrant, I think there's a broader distribution of cancers that we see within some of these families. So what's been interesting, again, to watch is what's happened with the turnaround time. The turnaround time, as I said, is able to support patients for making these real-time decisions, in many cases being able to get results in 7 to 10 days. Some of those larger panels, understandably, taking a little bit longer, but still within about 3 or 4 weeks to be able to get that information and to enable a lot of that real-time decision-making. On the other hand, as that happens, it really forces people to think about this sort of on the fly. You know, they really need to think and adapt to this in a relatively rapid mode when this information comes quickly. What's been interesting in this, and I know I've mentioned this one time before to this class, is when you think about variant interpretation, this is actually shifting and changing over time. And so now this is where you get to actually vote and help us decide in policy, because I know all of you weren't here when I asked this before. So with this information, we have these variants of uncertain significance. And when we have these things, they can either upgrade or they can downgrade, right? And so for those of you who don't know, we classify variants into one of 5 different categories. 1 is the most certain we are that it's pathogenic. 5 is the most certain we are that it's benign. And sometimes things shift around a little bit. A 3 could turn to a 2, could turn to a 4. They shift around a little bit. So one of the questions we have as a community of geneticists and professionals thinking about this is whether or not we return that information to individuals, to their providers, directly to patients. So as these variants get upgraded or downgraded, you know, should we release that information, or is it one and done? Or, I'll be even more provocative, should we leave it in your hands? Should we as a community be transparent and have some place where we can say, this is currently the way we classify this variant, you know your variant, it's up to you. You want to find out, you go on the web, you see this, it's transparent, you can know anything you want to, but we will put the locus of control as well as the responsibility in your hands. We will issue you that information, that first report. So I'm going to give you three choices. Choice number 1, one and done. You get a result, that's the end of the story. Choice number 2, you get a result, but you can opt in to have variant and reinterpretation over time. Some period of time, maybe you pay a fee for that. I'm not sure how we work out the details of that, but you know, you should be able to get that over time. Choice number 3, we leave it in your hands. We put that information in the public domain, up to you. The official policy of all of the governing bodies that actually make official policies on this is one and done. We issue this report once, we are done. We wash our hands of this. You have the information, you want to do whatever you want to do on your own, that's fine, that's up to you, but we are done with this. The reasoning being the following. What happens when you find this information over time, and what if me as a laboratory director, I give this now to you as a doctor, and now what if you can't find that patient? Do you want that responsibility? Do you feel that you need to have that responsibility? You have to go out and find them. What if they're dead? What if they've moved? I mean, how much responsibility do you place? How much liability is there on you if they make a decision one way or the other in terms of this? And so the concern has been that in those cases, you don't want to pass on that liability to the physician. And as a laboratory, you also don't want to yourself take that liability as well. So the easiest, cleanest way to do it is one and done. That's what you sign up for. That's what you get. The interesting thing is there's at least a wave for people to think about the third option, right? Which is that There's something, if any of you want to go online and see it, something called ClinVar. This is all about the idea that the variants will actually be in the public domain. This is an NIH-supported database which takes variants. You can see very transparently for any laboratory, if they've seen this variant, what they classified this variant as. And the interesting thing for any of you that want to go online is the discrepancy between different laboratories in terms of those. Ron and I were just talking about this a couple hours ago. And so, in fact, there is not yet convergence in terms of that variant interpretation, in large part because knowledge is still increasing. We're still clearly in the sort of phase of this where we're still learning very, very rapidly, and things are shifting and changing around. And I will tell you that for the most part, laboratories generally interpret this information in a conservative way, so that generally when they do this, they will downgrade in the sense that they will go from something they say is uncertain and eventually say it's benign. But in certain cases, they will actually upgrade, and that's important as well. And in certain cases, they will downgrade by going from something that was clearly a mutation to now actually saying it's benign. And I have to tell you, I've seen this on more than one occasion, because there's been some world-acclaimed expert who said it was a mutation, and everyone believed, because they said it was a mutation, that it was a mutation. And what do you know, when we started getting data to actually make a decision, they weren't such an expert after all. And unfortunately, and I have to say this, and I'm not joking about this part of it, we have had women who've had bilateral, oophorectomies, bilateral mastectomies, taken some pretty aggressive measures based on that information that was best available at the time, but on the other hand, not correct. And so one of those issues that we talked about is, again, that liability issue. So for those doctors, for instance, that were involved in that downgrade from something where a woman made a decision, lopped off her breast based on this information, and now comes back and says, what are you talking about? This is no longer a mutation. Like, what are you doing? I can tell you, those women sometimes come back and sue if they feel that, they've been harmed within this process. That's what the concern is in terms of doing this. This is not at all worked out, but it is something that's been very interesting to watch, I have to say. So within this, one of the things that's interesting is also how much you actually bring this to the public. And so one thing that Kathy and I think, have thought a lot about is there are a lot of women where the perception of risk is actually wrong in both directions. So there are a lot of women who actually may be at for sort of average risk, but have the perception that they're at high risk, and they can get really, really concerned about that. And on the flip side, there can be other women who are walking around thinking they're hunky-dory, but actually have much higher risk than they realize. So how do how much do you actually do this in terms of bringing this information to individual patients, to a community even, or to the public at large? So I'm just going to throw one idea out to you, because I actually spent the morning working on this and thinking about this. So what if you could develop an app for your phone, right? So what if you could develop a risk app for your phone where you would say, be able to put in a certain features in terms of your own personal history, your family history, have on the back end, we have these beautiful people like statisticians, molecular epidemiologists who are able to think about risk on the backside. What if it could have a complex algorithm on the backside and then put out to you, for instance, what your 5-year, 10-year risk of breast cancer is, what the probability is that you might have one of these mutations? Would that be a good thing? Would that be a good thing either just because we put it out there for everyone to use? Do we put it out there within a doctor's office where you would do this on a tablet before you go in to see your PCP or your OBGYN, when you're going to get your mammogram? Do we do it within that context? Do we do it in any other context you can think of, at a community health fair? But I don't know. Is that useful, number one? And as you do this, is that empowering for women to start taking the measures they need to in terms of risk reduction? And then if part of it is now trying to stratify your risk, because it's not just about that risk app. I can tell you, when we've actually calculated these risks, Mary Beth Terry and I have done this, you do that and you calculate those risks, and then you follow those women for 10 years to see who gets breast cancer. Only about 20% of the women who develop breast cancer were in the high-risk group. The other 80%, you wouldn't have predicted they were supposed to get breast cancer, but most of the breast cancer is coming from the women that you incorrectly modeled within that, and that you can refine that because you can actually do some better genetic testing. So I don't know, do you do the risk app? Do you do the risk app with the risk stratification, the better risk stratification with the genetic testing? Is this just raising a lot of sort of awareness and anxiety at the same time? Are we making for the worried well? I don't know the answer to that. So the idea is, in some ways, to be able to, do something, again, I think many of us have thought about this, I think about it in my practice in particular because I want to be able to make our healthcare system more, something that we're actually doing together. That is, patients are involved in the process, they're helping with this, they're also educated during that process. And so that's one of the things we've thought about, to be honest, just in terms of improving our workflow with our cancer genetics clinic as well, being able to have an instrument like that. So anyway, as we're doing this all for the service of being able to better tailor the care and also making it hopefully more accessible to even more patients as we go along.